This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host, and today I'll be interviewing Dr. Ron Schenk to talk about integrating MDT into MSK care. Dr. Schenk is a professor of physical therapy in the Tufts University GPT program and coordinates the MSK component of the curriculum. He is a fellow of the American Academy of Orthopedic Manual Physical Therapists. He is an orthopedic clinical specialist and McKenzie diplomat. In our discussion, we are going to talk about the efforts being made to integrate MDT into the standard of practice in physical therapy and the challenges faced in achieving the goal, the differences and similarities between MDT and manual therapy, and where other approaches are relevant. So if you find this information valuable, I encourage you to subscribe to our channel, click on the notification bell to stay updated, give us a thumbs up, and share with other clinicians you feel might benefit from this information. Thank you for tuning in, and I hope you enjoyed the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like
Fitter First, your first choice for the best Canadian-made rehab and fitness products since 1985.
Hi Ron, welcome to PT Pro Talk. How are you today?
I'm good, thank you. How about you?
I'm doing wonderful, thank you. So let's start talking a little bit about yourself first for the ones that don't know you.
Okay. So I'm a physical therapist. I teach at Tufts University where I coordinate the musculoskeletal component of the curriculum. I've been trained in manual physical therapy. I'm a fellow. Also, more recently received my diploma in MDT. And throughout my career, as I've been in clinical practice and teaching and really doing both at the same time, I've tried to integrate MDT into standard orthopedic practice, or what we consider the standard of care in musculoskeletal physical therapy. So I've done that through participation in FAAOMPT, which is the American Academy of Orthopedic Manual Physical Therapy, as well as the orthopedic section of the APTA, and in teaching, musculoskeletal on a full-time basis pretty much since 1989. But all during that time, I've been also at least half-time in clinical practice. And even now with my position at Tufts, I still do clinical mentoring for our McKenzie Fellowship and residency programs. And some of that's done virtually.
So that's a lot of experience in the area, and I guess it's a different view because you have the manual therapy with the MDT, so that's a very interesting combination that I'm curious to hear you talking more about it.
Right. So one of the things I've tried to emphasize along with my colleagues in FAAOMPT, the manual therapy community, is that both manipulation and repeated end range movements are end range forces. So in that respect, they're not different. The big difference, though, being that, in MDT, end range may be achieved by the patient and thus provide a means for the patient become empowered to self-treat and manage their condition independent of the clinician. So, and I think that's where Robin McKenzie met his opposition in the physical therapy community, was that, many of the outcomes he was achieving could be gained through the patient being in control as opposed to being manipulated. And McKenzie was a manipulative physiotherapist and was one of the founders of the New Zealand Manipulative Therapy Association, and did utilize those procedures as part of its practice, and still incorporated manual procedures in the management of patients according to MDT, but following the exhaustion of patient-generated forces. So I think when we consider end range as being a part of the motion or the range that can produce dramatic changes in the patient's mechanics, especially if it's their preferred direction or their directional preference, and when we see those changes in baselines, we can explain it via various theoretical models. McKenzie's original theoretical model being that of the disc, but there's emerging evidence in the literature of these end range procedures manipulation producing a neurophysiological effect that reduces pain and guarding and gets the patient moving again and functioning again. So, in that respect, we've had some success in presenting at the FAAOMPT conference and in explaining that, MDT does fall within the realm of orthopedic manual physical therapy, with one of the big differences being the emphasis on patient-generated forces initially.
Yeah, and I wanted to ask you, do you feel like the manual therapists, can they see that the same way that you see, or is it really hard for them to grasp that idea that it's the same end range, but one's patient-generated end range and the other is just the therapist applying the technique?
So, we all have our biases, and sometimes it's hard to let go of those. And I think one of the benefits of, our McKenzie fellows and residents in training potentially being part of the academy is that they see different views or schools of thought and maybe different approaches that maybe they won't adopt, but it does open their mind, I think, to the fact that when we have a system, when any of these clinicians who are very well schooled in a particular approach and know it at a very high level tend to have good outcomes with their patients because they have a systematic way of addressing patients. And the algorithm or the way about which they achieve those outcomes may be different. And then too, we have the evidence, which is, we're starting to see more and more evidence for MDT being effective. And at these conferences, we're able to, cite some of that literature, and, some of it is pretty powerful. And I think then it becomes more accepting. And I think it becomes more accepting too when it's presented in a way that isn't confrontational or isn't presented in a way that this is the only way or this is the best way. This may be according to our training or my training or a clinician's training, the way that we've seen favorable outcomes. It's not the only way.
Yeah. And I thought that was interesting what you mentioned before about the mechanism that it may end up being very similar. The when you manipulate, when you do end range, if you're talking about the neurophysiologic effects, right? Is that?
Yeah, we're not certain, right? We can hypothesize, and I think it's very useful and helpful to, hypothesize as to these mechanisms or maybe the pain generator, but we can't be absolutely certain that's what's happening in that individual that we're seeing. We may know in the future, but the other thing that I think has allowed MDT to be accepted more readily is the concept of directional preference. And when we find a preferred direction of movement that the patient can utilize and it improves their mechanics and how they feel, it's hard to argue with that. So we can argue as to the theoretical models, we can debate the mechanisms. But if someone tells us they move in a certain direction and now they feel better, they move better, their baselines are better. And, we've demonstrated that in some of the breakout sessions. That's pretty powerful. And not only that, but you move in the opposite direction or the direction that is opposed to their directional preference, and the mechanics are not as good, right? Or they decrease rapidly or they get worse. So, we can find that maybe moving to end range produces a positive neurophysiological effect. Maybe that's it. But why is it that when we move into the opposing direction and recheck the baseline, that now again they're worse? So there must be some mechanical as well as neurophysiological explanation for that. And that's for the scientists and those researchers that delve into that aspect of research to find out for us.
I just think it's so funny that there's all this fight about hands-on, hands-off, and then we are here talking about potential similar effects on both that could cause some pain relief, and it's just funny how that plays out. I'm sure that there is some mechanical, as you said, because you see that dynamic, but the other effect is also curious that you're mentioning, and I feel like people are just, my approach is better, hands-on, hands-off, and then in the end you have something that's kind of similar on both.
And one of the most powerful predictors of a favorable outcome among patients that we see is the therapeutic alliance. So when somebody has skilled hands and they're confident but not arrogant and they're listening to the patient, they've come a significant ways to getting that patient better right from that point on. So, again, there's a lot of factors that play into the patient's outcome. And mechanical is just one of them.
Yeah. And you mentioned that we use manual therapy in MDT. So, how often do you feel like we need to use to progress forces? Do you feel like that's very often or not really?
I would say as often as it's needed. So, not to be facetious, but based on the patient. I probably would put my hands on maybe sooner than maybe another clinician would. We don't know yet, based on the patient profile, when's the right time in general. I don't know if we will know, but if we, stick to the system and exhausting patient-generated first, and offering that patient the opportunity to self-treat as much as possible, then that helps our decision-making. I would say, I couldn't even say what percentage, but probably 70% of the patients I'll put hands on. But when is the question? It might not be. I try not to make it the initially.
And I feel like probably because you already use more manual therapy, so you would be more likely to use that with a patient than, let's say, like a therapist that just uses MDT and that's not as used to like manual therapy and all of that.
Right. But, it is right from the get-go in Part A, the manual procedures are taught. So a different algorithm or decision-making to get to the manual procedures than have it based on palpation or joint mobility testing or segmental mobility testing, but based on the patient's response. So.
And talking about manual therapy and MDT, that you said that both get to end range. So what would you make you decide between just doing more like a manual therapy technique, a manipulation or something, mobilization, something like that, versus going through the MDT approach?
Yeah, I would say a lot depends on the patient and their, whether they have yellow flags for psychosocial risk. What's their personality profile like? How willing are they to accept responsibility for self-management? Do they have an internal or external locus of control? So if somebody's, really believes and wants things to be done to them, and you do things to them, and they play a more passive role in their rehab, that could end up being problematic. But then again, it could be hard to shift that patient into, becoming more independent. So they got to be ready to do that, right? And we got to get them to buy into the fact that a movement in a certain direction that they can do could help them. So, depending on their psychosocial profile, their personality, how eager are they and how soon do they need to get back to their functional activity? If you're seeing an industrial worker, they need to get back to work that next day, or an athlete who needs to get back on the field, and they're highly motivated, they'll probably still do their exercises, but a manual procedure will move them along more quickly. I don't see a problem with that. And in fact, that may be what they want. So
Yeah,
that's
what I was
important.
gonna. Yeah, that's what I was gonna to ask you. Like, if you feel the positives of doing manual therapy, that you see the results quicker because you get there faster. But then the negative would be, in my point of view, that the long term, it's maybe not as good as when the patient goes through the education process of self-generated forces and all of that. Would that be?
I would agree with that. If you do a manual procedure too soon on a patient who isn't willing to be dependent, they may be dependent on you for a long time.
Mm-hmm.
And then we do believe that if they've learned to self-treat, self-manage, that may have a long-term effect, and that it may reduce recidivism or recurrent episodes. We don't have enough evidence of that yet, though, to say that. It makes sense, and we believe that, but I think we need to consider research that's going to support that to a greater extent.
Yeah.
We do have evidence in the lumbar clinical practice guidelines, in the 2021 guidelines, that MDT is an effective system in managing chronic low back pain. And I think that may in part be to what you're talking about. Maybe that in patients who are more chronic, maybe even who have psychosocial issues, if they've learned to self-treat, maybe they're reducing that chance for a recurrent episode.
Yeah.
Or maybe it's the empowerment.
Yeah. I think it's hard because we don't control those patients long term, I guess, to follow up and really see, because they might be fine, they got a manipulation, they got a mobilization, they feel better, but then you don't know down the line how they are going to progress because we don't track that. So it's hard to say and compare what is more effective, because short term it's fine, but then long term that it's the point.
Yeah, we have a lot of modalities or treatments out there, interventions that show short-term effectiveness. We need to investigate more long-term effectiveness, especially if we expect to impact healthcare costs.
Yeah. Yeah. And what are the challenges that you've been facing to try to integrate MDT into the standard PT?
Mm-hmm. Well, I think part of it is due to the fact that a lot of university professors have not been exposed to it, or they've been exposed to it only on a limited basis, or they may be familiar with maybe repeated movements in the sagittal plane, but not truly the exhaustion of the potential for directional preference by testing other planes and loading strategies. So, many of the university professors have been trained in other systems. I think there also is a feeling an impression that it can't be that simple. They're straightforward. But, I will argue, why does it have to be complicated? And I think you could still go with that concept of directional preference and still understand the arthrokinematics and biomechanics, because they may help explain at some point some of the mechanisms behind why things work, why these procedures work. But it doesn't mean we have to abandon them entirely. And again, I think it's even helpful to integrate it into standard education programs, following the active movements, the repeated end range movements prior to the passive movements. And you still want those students to learn handling skills and have them perform at a higher level from a psychomotor sense, because that's going to improve their handling of the patient and confidence that the patients feel with the clinician. So I think it can be integrated. I think part of the opposition is it's so straightforward. I think is somewhat challenging for people to accept. And I think not that many people have been exposed to it in its entirety at the university level. Maybe some have taken an A course, or they heard about it in school, but they haven't learned it to a higher level.
Yeah. And people think that it's too simple, but like the rationale behind and the assessment is not as simple as it seems. And I think that's most people don't understand.
There's a lot of clinical decision-making involved in it. And I think part of the thought that if it's maybe based on that percentage, maybe 50% who respond to sagittal plane end range movements, because that's the only movement you test and then it gets better, then it seems like it's simple. But really, when you talk about, when to change the load, when to change the force, and the direction, it's not that simple. But, it's still very logical. I should say logical instead of simple.
Mm-hmm. Yeah. There is a process behind it that
For sure.
follow, and
For sure. And that's not to be minimized by any means. No.
Yeah. And I just had an interview with Andrew Lowe, and he was talking about how P&E is now being introduced in the education system, on the education programs. So how do you feel like about MDT getting there? Do you feel like, I know that you've been fighting a little bit, so do you feel that we are far away from that? Because you said professors are not exposed. So like a way to change it would be being able to integrate that on the educational program. So how do you feel about that?
Yeah, so actually I do co-teach the pain science course at Tufts. And, we're building on the concept of directional preference in the musculoskeletal courses. And then in the pain science course, they could see where, if we find through a mechanical assessment that the person has a directional preference, even if they've had chronic pain and psychosocial issues, that they may respond favorably.
That's
so
awesome.
I think, and we actually have a research study, that is hopefully going to be accepted for publication that supports that. Even patients with high psychosocial scores, demonstrate improvement in those scores if they have a directional preference. So we found that in the lumbar spine. We just had a case series published in the Journal of Manipulative Therapy on cervicogenic headache. And many of those patients had chronic pain and high yellow flag scores and responded well because they had a directional preference. So, when that patient who has, sometimes overwhelming pain finds out that they can move better and they feel better from a straightforward movement, then they feel like they're more in control.
Yeah. It would be awesome if everybody could pass through the MDT assessment, and then part of that chronic pain group it be uncovered as just having a directional preference and then having like a quick resolution, taking them out of that cycle of chronic pain and don't know what to do and all of that.
Right. And then, too, though, and we all know this, there's patients who have chronic pain who don't show directional preference, don't have a directional preference. So we need strategies to manage those situations as well. But the traffic light guide is very useful. So its application, I think, to patients with chronic pain has its place, where the person learns the difference between pain that's increased and pain that's worsened. So when they understand that it's a yellow light, maybe we're emphasizing their function, paying attention to the fact that their symptoms aren't worsening, but having them focus more on their function without the pain, without becoming a red light, then they can, again, do a bit more each day. So graded exposure and the yellow traffic light guide, I think, are very useful applications of MDT concepts to chronic pain.
Yeah. And I think we have a lot of similarities with that system of gradual exposure by the way the MDT is designed itself. So I think that already helps us on managing those patients.
And I think that's why, the evidence is showing MDT is a good system for managing chronic pain in the lumbar guidelines. And I suspect the same would be true in the cervical, but we just don't have enough research yet to support that.
Yeah. And what do you feel like needs to happen in order to MDT be integrated in school in general?
Well, I think we need to have more professors and faculty who are familiar with MDT. We need to continue to present MDT concepts at conferences outside of MDT, outside the McKenzie conferences, but at FAAOMPT and APTA conferences and CSM and pain conferences. That'll play a greater role as well. So I think it's trying to get it out there in terms of what the students are exposed to before they graduate. And then, too, we also can capture audiences and people who are already fellows, who are maybe orthopedic clinical specialists, who are exposed to MDT through these conference presentations by our residents and fellows. The research, continuing to push the research that supports the system. Because when you see it up here in the guidelines, and the universities pretty much, or should be, teaching concepts according to the guidelines, once we get more and more into these practice guidelines, that can have a greater effect.
Right. Awesome. We were having a discussion exactly about that on our LinkedIn MDT group, that people were debating, older clinicians not seeing new grads familiar with this idea of mechanical assessment and repetitive movements and all of that. So I feel like that would be a huge step to get people more familiar with it, because everybody, I think, associates a lot physical therapy with manual therapy, and it makes a lot of sense to have a mechanical assessment, but I feel like a lot of people are just not exposed to it. And then they just somehow in their career run into MDT and for some reason end up liking it and pursuing, but I don't feel it's like the way that it's not common that every clinician has the exposure to it.
Right. I think the other thing that's having an impact is that a number of years ago, 10 of the McKenzie faculty decided to sit for the OCS exam. And they were prepared. Robert Metcalf developed a preparation course and study for them to prepare for that, and all 10 of them passed. So now when they're teaching a Part A, B, C, D, or extremity course, they're presenting it not only as a diploma McKenzie instructor, but also as an orthopedic clinical specialist. So when someone asks a question that falls outside of MDT, or maybe there's a patient who's being seen and they say, well, what about stabilization? Or what about manipulation? They can, of course, say that the concentration here is teaching a McKenzie. This is a McKenzie course. That's our emphasis. But there are clinical practice guidelines that you can refer to that have varying levels of support for these other interventions. Or patient doesn't have a directional preference or falls into the other category. So you can refer to this literature, you can refer to these documents to maybe address the other category, because that's not what we're focusing on in this course.
Yeah, that's how I was going to ask you also, where do you see other approaches being relevant?
Where the other ones do, where they may be relevant. Yep. So, I think the treatment-based classification system makes sense. You base the treatment on the classification that the person falls into. So, that research, you all from the University of Pittsburgh with Dick Earhart, who actually taught courses with McKenzie at one point. So in the treatment-based classification system, they have a specific exercise category. So people who respond to extension fall into that specific exercise category. And that becomes, the treatment. Someone has hypomobility, they get manipulation. They have hypermobility, they get stabilization. So in that treatment-based classification system, if you only test sagittal plane, about 50% of the patients will fall. The research shown about 50% of the patients could fall into that specific exercise category. But if you consider all the different ways of trying to determine if they have directional preference or may centralize, it may be, I think in Wernicke's research, 88% or more, right, may have a directional preference, if we're talking about the lumbar spine. So as you increase the numbers that fall into that specific exercise category, the other categories decrease in number. So the ones that have true joint hypomobility aren't as great, let's say, or hypermobility, or let's say mechanically unresponsive radiculopathy, right? So that's where I think the other approaches become relevant, right? So I think there may be a place, certainly for other treatments. It's not the end. We know MDT is not the answer for every patient that we see. We recognize it as a great system that has increasing amount of research support, but it's not the only thing out there. And, when you think too about, as I was mentioning earlier, the person needing to get right back to their activity, or needing to get right back to work. So one of my graduates was the head of a sports medicine team for a professional hockey team and NHL team. And we were talking about dry needling and MDT and where he sees MDT fitting in. And, I was asking about dry needling. And he said some of the players request dry needling between periods of the game so they can get right back out onto the ice and play. So in that situation, that modality is providing immediate short-term pain relief. And then when he sees them in the training room afterwards and follows up with exercises and so forth, and that kind of opened my eyes to the fact that, there could be varying rationales for utilizing some of these other interventions or modalities in a certain patient. And I did a podcast with a colleague of mine who's a proponent of dry needling. He's done a lot of research and political action in regards to dry needling. We talked about dry needling and MDT. And he's familiar with McKenzie, had taken A and B, I think. And, we talked about a relevant trigger point, an active trigger point, as it's called, or a latent trigger point, meaning, anyone could have a trigger point, but it not be related to their chief complaint. So he, talked about dry needling being most effective in those people that have an active trigger point. Another thing he talked about that I think is very familiar to people who practice MDT is they retest the baselines. So they have an active range of motion baseline or a functional baseline, and they go back and retest it following that procedure. He said when that's done in that manner, it's more supportive, can be more supportive for that patient. So, the big difference though being, where we may place palpation lower on in our examination sequence or schema toward the end, palpatory findings would have a greater emphasis, in that school of thought. So, but I was particularly impressed with the retesting of baselines and following it up with exercise and following it up with movement, because their goal is to get the patient moving again too.
Yeah. I think as long as you keep your eyes on the baselines and the patient is improving, doesn't really matter what technique exactly is getting you there.
That's what the patient would say. That's what the patient would say for sure, right? So, we would argue that, well, if we teach you, you'll have a tool to manage it in the future, prevent a recurrence, as opposed to things being done to you.
Yeah.
But they just want to get better, right? They just want to move better and feel better. And they don't care if it's Maitland or McKenzie or Paris or who it's, based on. Typically.
Yeah. I think I would always try to choose between, if I had to choose as a technique, try something active, because I know that the patient is going to have that independence, and I feel like long-term would be better. But I had many patients that they came and they said, like, I want you to do something for me. Like, I wanted to just receive it. They're not interested in doing anything. It was like, okay, you want to come back here every couple of weeks? It's fine with me. You are paying, you come back. And some people say like, yes, I do. So it also depends on the patient, as you said. But as a therapist, I would always try to choose something that would give independence, because we know that the long-term results are likely to be better and with long-lasting results. So,
yeah, patient preferences are very, very powerful. So we could try to convince that person that what we think is going to be more effective for them. If we get them to buy in, though, by retesting a baseline and they see it better, that's powerful. But if they have it in their mind that they want to get a passive modality and we try to talk them out of it, and we've created that wall between us and the patient, then
it's not going to go anywhere. Yeah.
No. Nowhere good.
And we were talking in another podcast here about manual therapy, and like some papers coming out saying that it doesn't have to be like a specific technique. It doesn't have to be as everybody thought that it had to in the past. So you don't have to be as skilled. You just have to give your patients the security, how to hold it, how to handle it, and you're going to have those effects. So I just feel like people have been just focused so much in manual therapy. We could split that attention between the general effects of manual therapy and then the effects of end range. Would that be ideal on our education? I feel like that would be the dream.
Yeah, it's interesting that these regional effects we see from manipulation and manual procedures are probably best explained by a neurophysiological effect, right? So we see thoracic manipulation helping people with cervical pain or shoulder pain. And we see a general lumbopelvic thrust technique helping people with low back pain if they meet a clinical prediction goal. So I think a lot of those outcomes may be attributed to more of a neurophysiological effect rather than a mechanical effect. But if we think about it, if we've exhausted cervical, let's say someone has cervical pain maybe even radiculopathy. We've exhausted cervical procedures. What do we go to? Thoracic. Right? We do thoracic procedures and they get better sometimes, right? We see that with the shoulder. I saw a video of a McKenzie International instructor and somebody with shoulder pain improving dramatically from a thoracic manual procedure. So, that's not an end-range cervical procedure. So there's got to be some neurophysiological explanation for that.
Even lateral shifts, John was talking about the thoracic impact on lateral shifts. So that's pretty crazy too. We're finding more and more connections between thoracic and lumbar, cervical. It's just that.
That thoracic region is, that's a powder keg neurologically. And, we see dramatic effects sometimes with thoracic manipulation.
And we know that research takes a few years to be implemented into practice. So you mentioned about getting on the guidelines and all of that. So how long do you think, would you predict if McKenzie keeps showing up on those guidelines and more research is coming, would take a little while for that to be implemented? Do you feel like?
A couple of years at least. So we actually received a grant from the International Mechanical Diagnosis and Therapy Research Foundation to support a randomized trial comparing the outcomes in people with cervical pain who exhibit directional preference, having them randomly assigned to MDT intervention or treatment according to the cervical clinical practice guidelines, because MDT is not in the cervical guidelines. So we expect that it'll take a couple of years to finish that trial. So from generation of an idea until the outcome of the study could take a while, but we're pretty hopeful for that study, and we'll see how it goes. It'll be a multi-centered trial. 3 clinics where the clinicians are duly trained in both the clinical practice guidelines and MDT. So they'll be okay with the random assignment. And we don't have evidence that directional preference is effective. Clinically we do.
Yeah.
Right?
That's going to be interesting. Curious to see that. So Ron, before we transition to the final questions, anything else that you want to mention about everything that we just talked about, integrating MDT into the standard practice? Any other thoughts?
Yeah, I think a message that we try to convey to our residents and fellows is that it doesn't have to be oppositional. Because clinicians who are showing up at these conferences want pretty much what's best for their patients. So if we go in with the idea that we're going to share what we know and do it in a confident manner, but not in an arrogant manner, not be dismissive of other approaches, speak to the evidence when we have evidence available, the results should take care of themselves. It's a slow process, though. And but I think we've gained some inroads in these other organizations, these bigger arenas, because we've approached it that way. And it's not us versus them, but rather what can we learn from each other to help the patient?
How can we complement each other? Each technique they're strong.
Without being dismissive. And, we've all been to continuing ed courses where the presenter may spend not only time talking about their approach, but knocking down other approaches. And that doesn't do anything for anyone. Certainly doesn't help the patient.
Yeah, absolutely. Ron, what is your favorite resource of information? Is there any papers, books, anything that you like in particular?
Well, I go to PubMed as a research resource. and looking at peer-reviewed literature whenever it's possible. So the Journal of Manual Manipulative Therapy is the official journal of the American Academy of Orthopedic Manual Physical Therapy, but it's also our journal. And we have representation, McKenzie reviewers in the editorial board. People are familiar with the MDT system, so we're seeing more and more MDT research in that journal. The Journal of Orthopedics and Sports Physical Therapy is, another one we should be targeting. And, that journal has a higher impact factor. So I think that journal publishes case studies as well, and I think a lot of what we're seeing work in the clinic, we should be sending those out, to that journal to get it read by a wider audience.
Yeah, absolutely. And what would be the best advice you give to clinicians that are starting their careers?
So I definitely encourage, our graduates at places I've taught to in the past to learn the MDT system. I teach them, I recommend that to them for a number of reasons. One is that they can continue their regular clinical practice while attending the courses. Most of the courses are offered in their locale. Now we have an online version of the courses that they can take. Because once they learn that concept of directional preference and they get a good handle on who may be responsive to it, who may become independent, then they can go to the other approaches or schools of thought for that other category. We need to do more to learn about and help us define the other categories as well.
Yeah.
Which is a project that I know the MII Education Committee is working on, helping define other, giving some direction for our clinicians regarding other.
Yeah, because sometimes we just go, okay, other, what do I do now? So, yeah.
And the other recommendation I make to them is that they find a mentor. So, try to find a position of employment where they have an experienced clinician they can talk to and share ideas with, or a group of clinicians. Try not to get into a situation where the emphasis is on how many patients you see. And you really need time in that initial examination to utilize all that you've learned and paid for in your DPT or physical therapy training. And you don't want to shortchange yourself on that, because then it becomes a boring job rather than a career. And frustrating. And people talk about burnout. And, part of that comes from not being able to use your skills to the best of your ability because of time.
Yeah.
So they need to be selective about where they work.
Yeah.
I understand, though, and we all understand the great debt that these students are leaving school with. And, money's a reality and a factor, I'm sure.
And I would say that's probably becoming harder because I feel like the load is just increasing, the amount of patients that clinicians have to see every day in these clinics, and it's just crazy. And what personal qualities or abilities that you think are important to become a successful physical therapist?
Yeah, I think interpersonal skills is number one. And then being able to connect with the patient. So regardless of what is, actually having that empathy or really caring and having concern for the patient. That's harder to teach. You can always learn skills and always learn techniques. The other thing is having a kind of systematic approach to things. So being able to categorize in your mind, at least, where to put all this information that's out there, because there's a tremendous amount of information out there. So having a being organized in the sense that you're able to put things into categories. So we teach patient-client management model. Cyriax first had this years ago. History, active, passive, resistive, neurological palpation. And that schema has been modified now into the patient-client management model, but still, if you have that schema or you have that organizational framework, as you gain more experience and exposure and learn more about motor performance and muscle balance testing, you put it into that category. You learn more passive techniques, you put it into that category. You learn more about motivational interviewing and yellow flags, you put it in your history category. So having some organization, time management is an important characteristic. And then being able to strike up a balance, not working to the point of exhaustion. You have to find out what's your outlet and what is your go-to to get your mind off of things physically, mentally, emotionally, so that when it's time for work, you work, and when it's not, you don't. But now we have, we got the phones, and we got 24-hour access, so people can get a hold of us at any time, and we're looking at our phones and email probably when we shouldn't. I think I've been guilty of that too. So when you get away, you need to get away, I think.
Yeah. Technology can be very overwhelming sometimes if you don't know how to do it. It sucks up all your time and energy if you're not careful with.
Yeah, you gotta be careful with
that. Ron, thank you so much for taking the time to come here.
Thanks for asking me.
Share your knowledge and your views on that MDT into our standard practice. So it was really good to hear your thoughts on it. And I was just going to ask you, if people want to get in touch with you or learn more about you, is there a way that they can find you?
Yeah, my email is ronald.schenk, SCHENK, at Tufts, TUFTS.edu. Ronald.Schenk at Tufts.edu.
Awesome. Thank you so much, Ron. I'm very grateful that you're here sharing your expertise with us today.
Have a good day. Take care.